A very warm good evening to one and all. I'm Dr. Kritika, President of IFReF, and I take great pleasure in inviting both esteemed chairpersons and our esteemed speaker from UK who spared her time with us. So first, I'll introduce the chairpersons for the evening. We have with us Dr. Jairani Kamaraj. She's one of the pioneers of doing IVF in Chennai, I should say. One of the few first people who had created an IVF as a separate field and have given a lot of importance and success to it. So she's a chief consultant in infertility and also takes care of high-risk obstetrics. She's a director of Akash Fertility Center and Hospital, one of the famous IVF centers of Chennai. She's a managing committee member of OXY. She's also the associate director of the Indian Institute of Sexual Medicine. She also acts as an advisor for the member of World Association for Sexual Health and also for the World Association for Sexual Health Media Committee. She has got a very major role in running the Ferticon conferences, the most, I would say, a very good conference that everyone looks forward to in Chennai. That's Ferticon. She's the organizing chairman for it. And it's been going on for more than a decade, if I'm right. And she's the organizing secretary for ICONS. And she's also a member of Indian Association of Human Reproduction. I welcome you, Dr. Jairani. And our next chairperson for the evening is Dr. Pavitra. She's a vice president of our IFReF. And she's right now the senior consultant of Chettinad Fertility Services of the Department of Andrology and Reproductive Medicine. So the same place where I had been graduated from reproductive medicine. And she's also very actively involved in academics. She's the editor of Chettinad Helsinki International Medical Journal. And she's an executive committee member of Indian Medical Association of Kelambakam branch. And she is actively involved in teaching the MCH aspirants in the Speed Institute. And of the other side, she's also got a lot of prizes for fine arts. She's a very good dancer too. And she has organized a lot of conferences, especially from Chettinad Helsinki. And her area of interest is subfertility and polycystic ovarian syndrome. So I think she will be very interested in today's topic of how to handle women with PCOS during an IVF situation. So now I invite the chairperson, Dr. Jairani, to introduce our speaker for the evening, Dr. Anu Chapla. Over to you, Dr. Jairani.
Thank you, Kritika. A very special thank to International Fertility Research Foundation, the president, you, Dr. Kritika, the vice president, Dr. Pavitra, and a very special thanks to the founder, Dr. Pandian, and the advisor, Dr. Radha Pandian. And I'm very happy to have this day to be a part of this wonderful webinar. And I'm very happy to be sharing this session along with Dr. Pavitra. And it's so nice to have such a nice topics on PCOS, because treating a patient with PCOS for ART, it's a real challenge for all the IVF specialists. We all know that the body weight, excess body weight, and the hyperinsulinemia, it really renders the management of this PCOS as a more complex one. The stimulation, on one edge we have the hyperstimulation, on the other edge we have the poor stimulation, and the quality of the oocytes, everything matters in PCOS, which is really different from the other scenarios. And I'm very happy to hear about all these intricacies in the PCOS management in ART. And to talk about it, we have with us Dr. Anu Chawla. It's very nice that she being an Indian and now a well-placed reproductive medicine specialist in UK from St. Bartholomew's Hospital. And she's a reviewer of international journals in medical assisted reproduction. And she's the member of the Infertility Committee of FOXY. And she's the member British Fertility Society, IFReF, ASRM. And she is a visiting consultant to Delhi in India. And she has been specialized with a lot of specialization in reproductive medicine. And she's here to talk about the ART in PCOS, which is a real important topic for all the specialists who are here. Over to you, Dr. Anuchola, for your deliberation on PCOS and ART.
Thank you very much. Um, one second, I'll just connect this. Thank you very much, Dr. Kamraj, for your very kind words and introduction. Thank you, Dr. Pandian, Dr. Kritika, Dr. Pavitra, Dr. Radha Pandian, Dr. Tupesh Khan, and Dr. Kanchana Devi, and my very dear friend Ajanta. Thank you for inviting me, and I would just kickstart with the presentation now. Can you see my presentation?
Yes, doctor. Yeah, we can see you now.
All right. So this is a very intriguing topic. I would cover PCOS and ART in PCOS as much as possible efficiently. There are no disclosures to make. The learning objective is to understand the key concepts and practical nuances involved in the journey of a woman with PCOS through IVF or ART. So if we see, understanding PCO has been a remarkably exciting journey for all of our gynecologist fraternity. In 1990, we had a meeting in the National Institute of Health in Bethesda. My sister is a doctor there, and I trained there also for a very short time in early 2013. And there was a first meeting on PCOS in that institute. Then we had the Rotterdam criteria, which is very popularly accepted even now, which happened in 2003 and majorly was contributed by ESHRE or NASRM. Then we had more important world meetings. And then recently we had a very important meeting, which was in 2018, which was majorly conducted by the members of ESHRE, but led by Dr. Helena Teed's team. And then we had a very important document, which we'll come to. So PCOS is a very perplexing topic and found very widespread. It has caught the eye of many researchers, and it is still a misnomer that we still have not changed. So we know that it is not cystic, it is follicles. So maybe polyfollicular ovarian syndrome would be a better name. And the incidence sometimes can be even higher than 1 in 6 or 5. And to address the whole picture, so we are in this particular talk covering very fairly narrow aspect of the whole problem, because it can be addressed by varied departments for varied aspects that it covers. So this is the document which was presented after 15 months of meetings. 71 countries had their representatives and 37 societies had the representation. And there were mainly 60 questions that they tried to address, and the team was led by Helena Teed. And the recommendations are divided into evidence-based recommendation or clinical consensus recommendation or the clinical practice points. So the evidence-based recommendation carry the highest weightage. If we summarize the whole thing in one slide, what they are saying is that first we should do the ovulogens, which is letrozole and CC, and we'll come to that fight a little later again in depth. Then metformin, when to add it, we'll come to that. And then the next step, is gonadotropin. Sometimes in selected cases, we do use both. We know that. Earlier, it was not very accepted, but recently we did have publications which support the use of both ovulogens and gonadotropins together in certain selected group of patients. Then it comes to laparoscopic ovarian surgery, which obviously involves the risk of losing the ovarian reserve if it is not with good hands. And third is IVF. Um, so this is the summary of the guideline. And coming to so I think the most extensive part of reading PCOS is the diagnosis. So it's very important to not miss something which is not PCOS is a diagnosis of exclusion also many times. But we have to make sure that if it is androgen elevation, then a quick way to check that is total testosterone. So the value that goes parallel with PCOS is 2 to 5 millimoles. And if it is more than 5 millimoles, you can convert it into other units if you're using other units. But if it is more than 5, it is not PCOS. It is something sinister. It could be an ovarian, it could be an androgen secreting tumor or anything else. So if it is more than 5, it could be congenital adrenal hyperplasia also. So check 17 OHP. If it is androgen elevation, then free testosterone diagnoses up to 50 to 60% of PCO patients. So free androgen index is what we use here, or we can do the calculated bioavailable testosterone, which is particularly set by that particular laboratory that we're going to. If at all they are not elevated and still we have a high suspicion, then we can do the androstenedione or DHEA. We must remember that if a patient is taking OC pills, then androgen elevation cannot be calculated, obviously due to the effects on the SHBG and altered gonadotropin dependent androgen production. Coming to the USG, 3D USG is very, very crucial and central to PCO, especially when we use Sono AVC. Even for the beginners, it's difficult to miss, and it's a very precise and accurate judgment for the number of follicles that we're looking at. We must remember that after 8 years of post-menarche, anyway, the ovaries can have multicystic appearance, and hence for those number of years, for roughly up to 23 years of age, all 3 criteria of the PCO diagnosis have to be present. And after 23, 24 years, then we say 2 out of 3. Also, the ultrasound probes are very, very efficient these days. So the threshold has been raised up to 20 instead of 10 follicles. I think this is wrong. So it's not 12 follicles, but more than 20 follicles. A typing mistake here, according to the new guideline. So this is very interesting. So this study was done in the Netherlands under the guidance of Professor Bart Forzer. So here, if we see, this is the whole different types of phenotypes that we see in the PCO. So what is yellow? Yellow is when we have everything. We have androgen elevation, we have ovarian dysfunction, and we have the polycystic ovarian morphology. And what is red? Because both of them are nearly 50%. So red is ovarian dysfunction with polycystic ovarian morphology without androgen elevation. And green and blue are basically androgen elevation with ovarian dysfunction is green, 4%, and even smaller percent is androgen elevation with the PCO morphology. So important thing that is highlighted here is that nearly 50% might not have androgen elevation, which is red. So androgen elevation. Now total testosterone identifies only 20 to 30% of women with PCO, but it is a quick first step that we can do. Free identifies 50 to 60%. Androgen elevation, like we said earlier, that free testosterone, free androgen index, and bioavailable testosterone are good first steps to see whether androgen elevation is present or not. If this is a little repetition. So differential diagnosis, all of these we must not miss when we are making a diagnosis of PCOS. We know there is a biochemical aspect that we can calculate, and this is just a brief summary if you want to take a screenshot of that. Now, PCO is not a cause, it is a result of anovulation. So when a number of months and years pass with no ovulation, then the ovaries develop PCO morphology. It is usually the other way that many of us assume, that because of PCO we have anovulation. No, it is because of prolonged repeated anovulation that ovaries become PCOM, which is PCO morphology. In this new guideline by Helena Teed's team, one thing is apparently ignored, which is stromal abundance, which is a very important hallmark and a very constant finding that we see. Richard Legro, we all know, he's done a very extensive research, and Nick Rainfanning, who is in here in UK. Both of them have done very good work in PCO, and they have really stressed on the fact of finding stromal abundance in the ultrasound appearance. Peak systolic velocity is higher when we see the hyperandrogenic patients, and peak systolic velocity is lower in the obese patients. Why is it important? Because it predicts OHSS. So 10 cc of ovarian volume criteria. Now this criteria can miss many of the weaker phenotypes, and those weaker phenotype PCOS patients are still at the risk of OHSS, miscarriage, recurrent implantation failure, hyperinsulinemia. So this 10 cc criteria doesn't really pick all of the PCO patients. Anovulation plus high LH. This results in the conversion of granulosa cells to the theca cells. So these are the interesting facts which are sometimes not clear when we read extensively, but stromal abundance tells us a lot about PCO patients and their performance during IVF, because they are the patients who will develop OHSS. Coming to lifestyle, actually, since the first day of our subject, we were told that even 5% decrease in the weight loss results in the improvement of the fertility. Now, obviously, lacking a data does not mean that we should not follow what is logical and obvious, but we do not have a data which support that. So there is absolutely no study that investigated the effect of healthy lifestyle on live birth, miscarriage, or regularity. Even if we have those studies, they are not conclusive, because we cannot make a conclusion because of many kind of bias that those studies had. This is a Cochrane database 2019, which said that there are no studies which are conclusive based on which we can say, okay, if the patient loses weight, there will be a higher percentage of live birth. But obviously, not having data does not mean we should not do that, but there are no studies. This is obviously a little later that comes into the lifestyle pictures of, obviously not the first line, but I thought, okay, let me mention that in the talk. So this is the FDA approved drug, GLP-1 analog liraglutide. So 3 milligram dose. This is FDA approved for the weight loss. We all know that losing weight is not easy for a lot of patients, and all lifestyle and diet changes even fail in many. And then we do the bariatric surgery, but that also has to be maintained. So it can be very challenging, and age becomes an important factor when we spend too many years doing that. So then we can use something like this because it is FDA approved, but obviously it shouldn't be used very early. So when we know that this patient has a PCO, would you go and test tubes because you have a clear reason for not for the subfertility? So would you go ahead and still do the tubal testing? So the recommendation in this guideline is that you decide based on the risk, benefit, cost, and timing. But when you suspect, because if there is a major sexually transmitted infections earlier, any other pelvic infections or surgeries done earlier, and if you feel there is a role for checking tubal patency, you can please go ahead and do it. So it's not that if she has PCO that then you only blame that. You can always go and check if there is a tubal factor in this patient. Predicting ovulation in an anovulatory PCO woman. There's a very interesting study again done in Netherlands. So what they did is the predictors of patients remaining anovulatory during the CC induction of ovulation in a normogonadotropin oligomenorrheic infertility. So what they saw was this. So they checked the screening parameters of free androgen index, BMI, mean ovarian volume, and cycle history. The combination of these parameters showed good predictive power whether this patient will ovulate with CC or not. LH, unfortunately, we think if it is high, we cannot use CC, but this study proved that it does not have any predictive value. Elevated androgen levels, those women have greater chance of remaining anovulatory even after CC administration. What is the place of metformin for a subfertile PCO? When we see that the patients are glucose intolerant, or they have insulin resistance, or they have BMI more than 35 is given in this guideline. Some other guidelines actually mention BMI more than 30 also. Or they are CC resistant, or there is a previous history of OHSS or miscarriage. In those patients, we can go ahead and use metformin. Interestingly, metformin is a long-standing, is a very old drug and has a long-standing history of benefiting many patients, and it is proven that it increases longevity. So there is a study which says the life expectancy increases when someone is taking metformin for reasonably good length of time. If someone is taking metformin, we must supplement or check vitamin B12 levels because they fall with the use of metformin. Principles of ovulation induction. So how do we choose letrozole versus CC? We do have option of letrozole now. Here in UK, we tell the patient that letrozole is available, but letrozole is not licensed for this purpose. But it is a first line in many clinics, but we always have to just document that the patient is agreeing to use it after knowing the fact that it is not licensed to be used for this indication. So it is off-label use, and we have to check the patient is not pregnant, especially in PCO amenorrheic patients, before we give them anti-estrogen. And unsuccessful prolonged use of ovulation induction agents need to be avoided due to poor success rates. Women with PCOS, significantly more likely to both ovulate and have a live birth rate with letrozole as compared to CC, the previous first line drug. Now, this is the international guideline, the IFReF team, the one that we're referring to in this presentation. They have taken letrozole as a first line pharmacological option. Of course, it is very important to write that it is after the approval of the patient. Now, this is very interesting. This is a very different kind of study. So we know there is a meta-analysis, but what is the individual participant data meta-analysis? So we know in meta-analysis, what we do, we choose studies and we combine their conclusions. In this kind of meta-analysis, we do not combine the conclusions. We ask the individual authors of those studies, those individual studies, to give us their data, and we collect the data, ignoring their individual conclusions. And we make a new conclusion. We only ask for the data and we reanalyze the whole data. So it's a very, apparently the most powerful way to study anything. So this study said that live birth rate and clinical pregnancy rate goes in favor of letrozole with the odds ratio of 1.4, but it only combined the data of 3 studies, which is too small in number. So that was the downside of this. Letrozole improves live birth and clinical pregnancy rate. It reduces the time to pregnancy. It probably is a good option to use as a first line. And it is influenced on, this is very interesting. Letrozole is influenced by the total testosterone level and CC plus metformin option. So if we have 2 arms, the other arm of CC plus metformin option is more suited for someone who is hyperinsulinemic. And letrozole probably is more suited for someone who has a higher androgen level. So when we choose what drug for which patients, probably this is another good way to think when we choose which one for which patient. This is a very interesting trial. So the goal of this trial is basically to determine the safety and efficacy of CC compared to letrozole in achieving live birth rate. And they have seen over 5 treatment cycles up to 25 weeks. And the arms are these 2, like I've mentioned. And they're examining the difference in the live birth rate in the 2 treatment arms. The results are not out yet, according to me. I might be wrong if they're recently out. I'm not aware, but till few months back, they were not out. But that will be a very conclusive study. So the whole confusion between these 2 drugs will go away once we have the result of this trial. We have a Cochrane database of 2 years. So this is 2014, in which they favored letrozole. They said that it appears to increase the live birth rate. The same study by the same authors was revised. And in 2018, they changed the conclusion because they only included the good quality studies out of that same, because Cochrane, we know why is it so popular, because it only looks into the RCTs, nothing else. So it combines the RCTs and then gives us the conclusions. What they did was they only included the good quality study, then deleted the others, and they revised the outcome. So then the conclusion changed in favor a bit of CC. So there is a high quality evidence. So we think that OHS is not very common in letrozole because it's a monofollicular development, but here it says that the rates are similar. And there is a high quality evidence of no difference in the miscarriage rate and also multiple pregnancy. So in 2018 update, we added good quality trials, upgrading the quality of evidence. So the same study, which earlier told us favoring letrozole, now has made a U-turn by including only the good quality trials. So we know that letrozole versus clomiphene citrate. So the loop, if we see the feedback loop, this loop is closed when we use the letrozole. And this loop is not closed when we use the CC. And that is why it goes on as a multifollicular development in the CC, because the feedback loop does not close there. So Again, there is an evidence-based recommendation in favor of letrozole according to this, but many senior people like Professor Bart Forzer, some studies that I've shared about the Cochrane review studies, they still have made a little U-turn in favor of CC again. So what happens with CC when we use clomiphene? Thin endometrium. So what can we do to, so if you did one cycle with CC and you thought that, okay, the endometrium really got compromised, what can I do differently next month? Again, if you want to repeat CC, you can just start the clomiphene a little early. So you can start on day 1. So that it has more time to develop endometrium later, or you can decrease the dose, or you can even start the clomiphene in the luteal phase of the previous cycle, if not even day 1. You can start even just before the periods even. So what is the ASRM guidance for ovulation induction in PCOS? They also favor letrozole as the first line, especially if there is CC resistance. But they say that use ultrasound monitoring, because we always should be wary about the multiple pregnancy. Gonadotropins, according to ASRM, is taken as a second line, but if there is an access and compliance for the patient to do regular ultrasounds, then gonadotropins can be used as the first line. I am aware of a few very good senior practitioners in UK who only use gonadotropins and do not use letrozole and clomiphene at all, because they think their even IUI results are better with the use of gonadotropins as the first line. But the condition is patients should be willing to come regularly for an ultrasound so that you can chase closely for the multifollicular. And if there is more than 3 follicles of 14 millimeters, then we cancel the cycle. So that is the baseline principle. What about the drilling? This is again the Cochrane database. Is pretty recent, just a year back. So this says that it decreases the live birth rate compared with the medical ovulation induction alone. And also it reduces the multiple pregnancy, but honestly, drilling is a very surgeon dependent procedure. So if we do less punctures and with a good quality surgery, the results can be different. But according to this Cochrane database, it says that there is lesser live birth, lesser multiple pregnancy, lesser OHSS, and uncertainty about the miscarriage, and insufficient to justify a conclusion on the live birth rate, clinical pregnancy, or miscarriage for the unilateral versus bilateral. So we still don't know whether we should, some people do have this thought that should we do only one drilling for only one ovary, but that is still to be studied. We don't have enough data to comment on that yet. It is taken as a second line therapy for those who are clomiphene resistant. So this is the take home point about the place of drilling here in the management of subfertility in PCO, that if the patient is resistant to ovulagens, then you can go ahead and do this. Gonadotropins also is taken as a second line treatment. Like I said, first line if ultrasound is there. Third line, coming to the IVF now. So we do not need to go to first or second line necessarily. We can post the patient for IVF directly according to the patient's choice also, and after 2 years of subfertility according to NICE guideline also. So if there is 2 years of subfertility, then you can skip first and second line, you can go ahead with the third line, or if the patient is of the older age group, you can go ahead and give her the option which gives her the highest chance of success rate without getting more older. So when we do IVF, it's a very common practice that many people want to use only the recombinant FSH. Is that right? Probably not. And this will be further proven when megaset trial, this was further proven when megaset trial outcome came, which used the highly purified HMG and proved that there is no difference between the rec FSH and highly purified HMG. Then segmentation approach, we'll come to that. And IVM is still experimental in the place of IVM is still not very acceptable unless the standard of the lab is cutting edge and they have enough expertise on IVM. Place of IVF in PCOS is not only because of the larger set of developing follicles. The place of IVF in PCOS is also because we have to work on the uterus, which we often ignore. We'll come to that. And we can have an option to do an elective single embryo transfer when we are doing IVF. So all these situations can push us towards IVF much more quickly than proceeding with the first line of ovulagens in many patients. Pre-IVF treatment. So what is the place for pre-IVF treatment? With some people use OC pills before IVF or ICSI regularly. Is that the right thing to do? We still do not know because there are two schools of thought. So one school of thought says that overall, 2 points are there. Whenever we use OC pills before the IVF, two things will happen most of the times. One is the total consumption of gonadotrophins used for the same kind of cohort development for this patient is going to be higher. So she will use total higher dose. Number two, she will use gonadotrophins for longer number of days. So maybe 10 to 12 days is something that she might need otherwise, but because of pre-treatment with OC pills, she might go up to 14 days or longer than that. Good point. Another school of thought is that some people like giving OC pills before IVF, obviously because they want to do batch practice, but more scientific reason for some people to follow that is that what OC pills with pre-IVF treatment will do is that they will weed out. So normally there are some poor quality antral follicles which are supposed to undergo atresia, and they do not undergo atresia otherwise. But when we give them OC pills, it does the weeding out, or it kills off the non-atretic, simply lying, poor quality pre-antral oocytes, which do nothing, do not give us eggs, but only cause OHSs. So it prevents the OHSs and hence is favored by some people. And Sherman Silver, who is a very senior practitioner, probably the oldest guy practicing IVF, he favors that. What is the place for pre-treatment OC pills? So negative and positive. Negative is overall consumption of gonadotrophins increases, pregnancy rate decreases. This is all based on some studies. Length of stimulation increased, dose of gonadotrophins higher, lower number of oocytes, obviously because the non-atretic ones have gone away. Plus point is weeding out, killing off, and in selected cases, it does the coordinated cohort that we achieve is going to give us a better pregnancy rate. That is also one more point in favor of that. What is the combination? So when we talk about the donors, especially a lot of number of cases in India are egg donation cycles and depending on the unit. So what happens when you stimulate a donor, you always are very worried that there should be no complication to her. So normally they are younger women, sexually active, and they already are on OC pills. Later, when they do egg collection, the doctors want to keep them safe. So the doctors have started using GnRH agonist trigger very often for donors. So what is wrong with that? When a woman is on OC pills, her endogenous LH is low. And GnRH agonists need a certain level of LH to work. So if the endogenous LH is low, then this agonist trigger is going to compromise. So you will not get as many eggs. So it's not a good combination to give OC pills first and then uh, do the GnRH agonist. So if you want to give GnRH agonist as a trigger later, make sure you take off the women from the OC pills, at least for the 3-month period. AMH. What is AMH? AMH is still not understood very correctly. Should not be used to diagnose PCO because we don't have a clear cutoff. Inherently, it is an inhibitory hormone and it suppresses the femaleness of the developing embryo. That is how we understand this hormone. It is an indirect indicator of what? It is going to tell us the number of follicles which are kept suppressed in the ovary, what we see as a multifollicular picture in the PCOS. So they are kept suppressed by the inhibitory hormone called AMH. So predictiveness for OHSS is high, but it is not to be used to diagnose PCOS. It should not be used because we do not have the cutoff to follow to diagnose the PCOS. So IVF or ICSI for PCOS. Now, it is a third line. We can reduce the multiple pregnancy and we can control hyperstimulation by segmentation approach, which we'll come to. Urinary or recombinant, both can be used. Recombinant LH should not be routinely used. So Luveris, which is actually very popular in UK private units, not in the NHS units. I worked in both. So Luveris, which is recombinant LH, is pretty popular in the private units, but it is not evidence-based. Place for metformin before and during the IVF in PCOS. There is no conclusive evidence that it improves the live birth rate but yes, it does increase the clinical pregnancy rate and decreases the risk of the OHSS. Now, which protocol is the best protocol? I wish I could ask questions with the live poll. Maybe we can do it next time. Before I go into different sections, it's nice to know what kind of practice is happening so that I don't put myself into trouble by saying wrong things. So IVF stimulation protocol, which is a better protocol? In general, if we see, there is a U-turn coming in favor of long down regulation again. Overall in UK, if you ask me. I'm not aware about India recently. I'm usually aware about India, but recently I've not been coming for a year, so I'm not aware what actually is happening in the units. IVF stimulation protocol. So the evidence-based recommendation according to this guideline is antagonist protocol is preferred in the PCO women over a gonadotropin releasing hormone long agonist protocol. So they are favoring antagonist according to this guideline in the PCO women. Obviously, there are many studies which say 15 is a number by some studies and 27 by some newer studies which say that this is the number of eggs that we need to make sure that we make the woman pregnant if there are no other major issues. So that is the reason that antagonist is sufficient, because you're going to get that many number of eggs in 1 or 2 cycles of PCO women without going for long down regulation, because the only reason why U-turn is happening in favor of long down regulation in some of the units is you get more number of eggs in the long down regulation, which is not the main concern in PCO. What about the trigger? Triggering final oocyte maturation with gonadotropin releasing hormone agonist and freezing all should be considered when having the antagonist protocol, because these women are on the risk of OHSS. Let's compare. There are 8 studies what happens? So statistically significant difference is there in the amount of gonadotrophins, in the duration of gonadotrophins, and in the rate of OHSS. And no statistically significant difference is found in the pregnancy rate, miscarriage, oocyte cancellation, or multiple pregnancy rate if you compare these two protocols. Um, so depending on what is the most important parameter in this particular couple that you're treating, accordingly, you can still choose between these two protocols. This we have seen. So drug, I would skip this. So this is another way to work. Some units do it, especially the beginners, someone who is practicing IVF for less than 5 years. I would say reasonably good reason to use indices like this, which is follicle output ratio. So it actually is the pre-ovulatory follicles with respect to the antral follicle count, and the follicle oocyte index is the, so these are the indices followed in various studies, so we develop better understanding. Otherwise, you don't really need to use them. It depends on if you want to incorporate this as a part of the protocol in your unit. There are some online calculators, ART calculators, in which you can see this kind of number of oocytes that you should keep in your mind to target, which is less than 35, 8, and then advanced age 11, and then after for 40, 70 number of oocytes which are recommended. These are all based, they are taken from some recent studies. Coming to this megaset trial, I think I've already discussed this. I will skip this. Segmentation. So segmentation is 3 steps. Uh, this is an approach to make sure that we do not do hyperstimulation and still give a good pregnancy rate. We have to remember that we can only do it when the laboratory is giving us a good pregnancy rate with the good success outcome with the vitrification program. Some units still might be new in that. So in those units, this does not apply. Only with the laboratories with good vitrification program this applies, because if you do not have a good vitrification program, then you can't miss that golden chance to put a fresh embryo in that woman. So antagonist protocol followed by agonist trigger and then vitrification. So agonist trigger is going to switch off the, so still some people do go ahead, but the live birth rate is very low. If you do the fresh transfer after using the agonist trigger, they do very heavy doses of progesterone and still go ahead, but that's not what we should do. If we have used agonist trigger, we must do the freeze all. Trigger. What does it do? Basically, it does the nuclear as well as the cytoplasmic maturation, which are independent of each other otherwise. GnRH agonist work at the pituitary level. Newer drug, we all know, kisspeptin, still to come in the practice for everywhere. It works at the level of hypothalamus, even higher, and there is a role of dual trigger these days. So if you want to take a screenshot of all the common drugs used in the trigger, this is it. Dual trigger, there are 2 very important studies. One is this, which said that if in the first cycle you had lesser number of mature oocytes, dual trigger, meaning using both agonist and HCG, if not only agonist, might give you the higher chance of mature oocytes. Another study is this one. This one said that significantly improves the live birth rate for women with the diminished ovarian reserve. So indication for freezing all is when you want to do the genetic testing, or you have too many follicles, or you have the progesterone elevation more than 1.5 on the day of the transfer, and you have poor endometrium. Please remember, sometimes we see a polyp. Actually, we see too much because ultrasounds are very good these days. So if we see a polyp during the stimulation, which was not seen earlier, before starting the stimulation, that polyp is actually an endometrial fold. It's not a polyp. There is an entity called endometrial fold. And if you see on ultrasound, it looks like a small polyp. If you actually go with the scope inside, do a hysteroscopy, you will see nothing. So those polyps which are seen only in the ultrasound during stimulation and were absent earlier should normally not change your plan to do the fresh embryo transfer. Complications, these are the mainly three. So OHSS, multiple pregnancy, and those women who have higher androgen levels, they miscarry. Significantly higher chance of complications in maintaining pregnancy if they've had a pre-pregnancy higher level of androgens. Like we already mentioned earlier, we can predict OHSs by doing a very close ultrasound, seeing the stromal abundance and seeing the higher peak systolic velocity in the stromal arteries of ovary before we go ahead with the treatment, and we can take out, really predict OHSs before even it happens. So these are the few things which people use. We don't very often, we hardly use, I have not seen anyone using albumin here, and that should not be a common practice because it can cause major allergy. So all these things that I've mentioned, they do not reduce the risk of OHSS. Very interesting. This is the NAS US data. Nearly all, 97% of all IVF cycles done in the US from 2000 to 2015, just less than 2 million cases, they all were taken in this study. And they noticed that basically the only thing that changed. So the antagonist cycle was the only thing that was rising, and OHSS was decreasing over the number of years. And definitely that means antagonist cycle prevents OHSS. Outcome, if you got more than 15 mature cycle, it should be considered as a good stimulation. Use of antagonist when appropriate, use of agonist trigger, use of metformin, who are at the higher risk of OHSS, is also advocated, and embryo cryopreservation. Now, I'm just skipping a few that I've covered. So OHSS is associated with low birth weight and preterm delivery. And these are the obstetric risk ratios that we see in a case of PCO woman: early pregnancy loss, PIH, perinatal mortality, gestational diabetes mellitus, preterm labor, small for gestational age, and the higher chance of cesarean sections. IUI results in more multiple pregnancies than IVF. This is very, very important to notice that it's not usually IVF, it is IUI that is going to give you multiple pregnancy in PCO patients. This is interesting. So maybe PCO is a good thing for older women. So this is a silver lining. So I try to see good in everything. So the silver lining I see here is we now know that the age of menopause in PCOS is later compared to the general population. We assume ovarian aging is lesser prominent in the PCOS. Maybe they're more fertile than a normal non-PCO woman at 40 years of age. And that is a very common age around me when patients come at that age. Just an interesting thing to share with you, there is a new needle-free IVF already being practiced by Dr. John Zhang in New Hope IVF Clinic in New York. And I went there and I saw they do IVF with no needles. So how do they do it? There's an oral antagonist tablet, and otherwise they use the CC. So clomiphene, letrozole, and elagolix, which is the oral antagonist tablet. So all that combination gives you a decent number of eggs, and the only needle that goes in the body is when we do the egg collection. So thank you very much. And if there are any questions, I'm happy to take them. Thank you for your time and for your patient hearing.
Thank you very much, Dr. Anand Chavla. It was a very elaborate presentation. You had mentioned about right from the pathophysiology to the investigations and the various aspects in ART, including the complications. So I would first, I have a lot of things to discuss with you too, but I would first like request Dr. Jairani to say a few words. Then I will go into the discussion part with you, and we do have some questions from the participants also. I will discuss them with you after Dr. Jairani finishes her discussion.
So thank you, Anushala, for this wonderful, very elaborate, very detailed, every point to be noted. You have very much insisted on everything. That's so nice that you have made everything as a comprehensive one for all the participants to know every detail about it. And very nicely you've talked about the weight reduction, BMI, and all the details and depth as a practitioner, as a clinician. All should know about PCOS when you encounter any PCOS women, how to tackle them, how to manage them. You are given a very, very wide, good deliberation. It's so nice. And I thank you for this nice presentation. And we are there having a lot of questions in the chat box. I'll be happy if Dr. Pavitra can
Sure, ma'am.
pick up the questions.
Yeah.
Thank you very much.
Thank you, ma'am. So before going to the questions, I would like to have a short discussion with you, Dr. Anu. So PCOS is my favorite topic.
I was scared when someone told me that I was like, oh my God, let me change the topic now. A super researcher in PCOS sitting with me as a moderator. So maybe you can teach us a few more points. If I missed anything, please add them first before you ask me questions.
No, yeah, it's just a discussion. Okay, like this is a mutual learning. So this is a discussion that is going to happen. And see, like most of the points, we were in the same wavelength actually. So as you said, it is a misnomer, and it is actually polyfollicular ovarian syndrome and not polycystic ovarian syndrome. And you beautifully said it is repeated anovulation that leads to PCOS. So wherever I quote we, it actually means me, my Professor Pandian, my mentor Pandian sir, and Radha ma'am. So all of us think that this is how it works, like anovulation leading to PCO. Because what happens is when we think the other way around, when we think
it doesn't explain
ovarian morphology which leads to anovulation, that is when we start concentrating on treating the polycystic ovarian morphology, which is actually normally seen in at least 20 to 30% of women who conceive naturally. So we believe that it is not the polycystic ovarian morphology which actually has to be treated. So it is the anovulation. When a woman comes to us, we should consider if her as PCOS only if she has anovulation, because when it comes to infertility, all that we are worried about is the ovulation part.
Yeah.
So that was a very good point. And yes, of course, we have done studies where we've seen that the BMI has nothing to do with PCOS most of the times. It is the weight gain. Most of the women whom we see have had weight gain at some point of time after the adolescence. So these are the women who land into PCOS. So I would be happy to share my articles. You have your email ID. I'll share my articles with you. And you also mentioned that letrozole, we should not always consider that only monofollicular development will occur with letrozole, because we do see multifollicular development. That it is a very important point, because they have to be monitored. Just because we give letrozole, we shouldn't think that she's going to have monofollicular development and not do the ultrasound monitoring, because that is actually very important. So I wanted to ask you, what do you think about the mild stimulation with clomiphene citrate and gonadotropins together in PCOS for ART? Low dose gonadotropins along with clomiphene citrate.
Yeah, so like I said, the New Hope Clinic. So John Zhang is a super doctor, according to me, and he does that. Most of the Chinese doctors do that, and they are very good. Earlier, I didn't used to really advocate that, but when I visited their units and actually asked them what are their experiences, results. So they are very happy. Mild, I wouldn't call it mild, to be honest. Mild is really when we start the stimulation after 5th day of the cycle. So that is what I call as mild. We only support the natural cycle there. But this is a stimulation because we are using gonadotropins. We use CC is not weak; it's a strong drug. It does create multifollicular development. Pretty often, the moment you touch 100 or more, uh, if it can go out of control. So it is not really mild, but yes, milder than if we are comparing with 300 dose of gonadotropins. Um, it has very much the role, the place in IVF as well as IUI, because like I said, we don't need the supernumerary, non-atretic, just lying weeds, those extra follicles, which are not doing any good to us. So they are not going to grow with CC plus gonadotropins. Only those which are going to give us eggs and good quality probably will grow with CC plus gonadotropin. So that is a good combination. Yeah, another thing which someone told me that in South India, people add LH and people change gonadotropins after a few number of days. Is that right? So after a few days, they change the type of gonadotropins they use. What is that?
We don't practice that. We
Hmm.
actually
A
are
pharma person
more
told me, a pharmaceutical company told me that the demand in South India is a bit little different because they use different for the first 5 days and later. So I thought, okay, if I go in one of the South Indian societies, I'll ask them, because if it is something interesting, I would want to know what is that.
Yeah, I just want to add up, Anu, as it is. So when we start the stimulation with a recombinant, then after 5 days of stimulation, we add up a HMG along with a
Hmm.
recombinant. That will give a, because especially in the agonist cycle, we won't do in the antagonist cycle, it will be done in a long down-regulated agonist cycle. You can add a uh, HMG along with your recombinant. That will give you the LH. Sometimes when you start with a long protocol, your LH, everything will be very much suppressed on the day
Yeah.
two. So on the day
That's
five,
what I was thinking, that it has more place in the long
yeah,
protocol
so
and
after the
maybe
5 days of
non-PCO
stimulation,
patients.
add a HMG. That will give you a good LH for the follicular, for the proper, quality of the oocytes. Definitely, it is little more good. You start,
Hmm.
we all have in the long protocol, we add up a HMG along with a recombinant, and they give a good quality of the oocytes.
Okay.
Yes, many centers practice that, and it is
Hmm.
the I think Radha Madam and Dr. Pandin sir can comment on this, because when we all started our IVF unit with IRM, we always have that type of stimulation. We start with the recombinant and then add up a HMG. That will give a good quality oocytes, definitely.
Okay.
we like since the time I joined Professor Pandey and Dr. Radha, I've been seeing that they've been using urinary products, like the
Hmm.
G for all patients, and we do have good results with that.
Even for PCOS?
Yes, ma'am. Yes, we use
Like
HM.
Megaset trial, I said. So Megaset trial said
We've always
that
been using.
highly purified HMG is equally good, and there is no reason why we should do the recombinant. So it's a very, very nicely performed trial, and the results are pretty conclusive that it is very equivalent to use HPHMG or recombinant. One of my very good friends, Dr. Jatin Shah in Mumbai, he's a big supporter of that. Highly purified HMG is an equally good option in PCO, because the only thing that is going to do that, actually it decreases the chance of OHSS. Again, the same non-atretic weed like lying follicle is going to not grow with that, which we want.
Yes. So also the clomiphene citrate, we also follow the clomiphene citrate with gonadotropin protocol, the low dose gonadotropin
Yeah,
protocol.
yeah. Yeah.
We do that also for women with these multiple follicles for whom we want to prevent OHSs, and also for women whose male partner has severe oligozoospermia, where we do not want too many eggs also. So we go for this clomiphene citrate and the low dose gonadotropins, and we do have good results with that protocol too.
So when the indication is not female, it's some other indication like male factor, then we know that the eggs are going to be good quality and it will perform good result even with less numbers. So we don't need to create a lot of hyperstimulation for her. We just need few eggs. That's it.
Yes.
Correct.
Thank you, Dr. Rano. So shall we go ahead with the messages in the chat box?
Yes.
Yeah. So we have Dr. Radha Pandian. She has said she wants to share a few thoughts. So she says that there should be no compromise on weight loss. Newer drugs act unphysiologically by suppressing the appetite. So we usually don't prescribe metformin or any.
Sorry, you don't.
Yeah, we don't. We usually go. Like weight loss is the first recommendation that we give, and we do not add metformin because most of these studies also say that it does not improve the pregnancy rates or the live birth rates. So we usually don't go for metformin. And her second point is laparoscopic ovarian drilling, however skillfully done, it is very likely to reduce it. It is very likely that the ovarian reserve reduces. So again, we don't do laparoscopic ovarian drilling for our patients at all. So because there are
hardly do it. Hardly.
a lot of patients who've had laparoscopic ovarian drilling and they come to us, but still they continue to have resistant anovulation, and there are studies which say that their clinical pregnancy rates or live birth rates do not improve with laparoscopic ovarian drilling, and when they go to ART, again the number of oocytes and the number of embryos they get, the women who underwent laparoscopic ovarian drilling, it is on the lower side. So they say that the cumulative pregnancy rate can also go down with ART if they've had a laparoscopic ovarian drilling earlier. So with keeping these things in mind, we usually do not do a laparoscopic ovarian drilling. So her third point is that OHSS is an idiosyncratic phenomenon. Anticipation and judicious monitoring are the only ways to manage it. I think you would agree with this.
So OHSS free clinic is only an aspiration, still not fulfilled. We only want our clinics to be OHSS free, but no clinic is OHSS free yet. So I totally agree with that.
So ma'am has asked about your observations in different PCOS phenotypes during ovulation, induction, and ART.
So I would say that hyperandrogenic women in the rural area who cannot come very often and who cannot do repeated IVF, who are poor women, they are good candidates for and non-obese. So hyperandrogenic, non-obese, rural setup, poor, financially not affording IVF, that patient should be offered ovarian drilling because they might start ovulation and they might get pregnant on their own because they're not going to come to us again and again. So it's better to do something for them. And drilling is not a bad thing. So basically, what keeps the ovarian reserve a reserve? I'm just going a little tangential, but it's a very interesting point I want to share with you. So Sherman Silber, he's a very big researcher. He's working with Hayashi's lab in Japan, where they have created small mice from the skin cells of mice. So we might not need ovaries after few, or maybe I don't know how many number of years. So some of my friends who are of the age of 43, 44, still single, they ask me, Anu, how many years will you take to give us babies only from skin cells? Because I keep telling them this, that has happened in mice. But I don't have the answer that how many years will we take for humans and for this technology to come in practice. So the concept is that ovary has a capsule, which is the thickest tissue in the body, thicker than the Achilles tendon. So ovarian capsule is the thickest tissue in the body. Why nature has made it so thick? Because the sheer reason to not ovulate all of them together and to keep the follicle reserve is physical pressure. There is no biochemistry about it. There is no hormone about it. Okay, anti-Mullerian hormone, we understand that as something which is inhibitory for the ovulation, and that causes higher AMH level causes ovulation, but we don't know whether that presence of high AMH is also related to the thick capsule, because of that thick capsule, the reserve is a reserve. So that is the principle on which they have worked. So what happens is when the capsule is very thick, the nucleus of the cell starts rotating and it becomes dormant. And when the movement happens, they go away from that pressure. The nucleus stops rotating, and that is when the cell can grow. So it is actually physics more than chemistry that works. So because of this thick capsule, those nuclei rotate and the cell is dormant and it is reserved as a future follicle. But I now forgot what was the point that we were talking about. Why was I talking about this? So what was the point that you raised?
It was about laparoscopic ovarian drilling.
Yeah. So what the laparoscopic drilling is going to do is it is going to release that pressure.
Okay.
And ovulation will happen.
Okay, I get your point. Thank you, Dr. Anu. We have a question from Dr. Kanchana where she asks whether AMH level can predict the resistance to ovulation induction.
Yeah, so anti-Mullerian hormone is going to basically, AMH is the reason of non-ovulation. It is, what is AMH? AMH is making sure the embryo does not become so it suppresses the femaleness. So AMH is anti-Mullerian hormone. It is it's a hormone that we still understand as having a role in the developmental stage of embryo in the formation of the gender. So obviously, yes, ovulation, a high AMH is the cause of non-ovulation and ovulation.
Okay. Thank you very much.
Pavitra, I just want to comment on one suggestion, one talk you made. That is, you don't use metformin for your PCOS in your center. I mean, in Chettinad Hospital. I just want to know how you treat a PCOS woman with an insulin resistance which is high, when she has a abnormal glucose tolerance, when she has all the features of hyperandrogenism. You don't treat them with metformin?
If she has impaired glucose tolerance, yes, we do give her metformin, but that is
So
the
in
only
those,
for which we give metformin. Otherwise, we don't.
which
She
is
can't-
the indication of place of metformin by IFReF guidelines, which I already put in one of the slides, that where is the place of metformin? So high BMI, glucose intolerance, hyperinsulinemia. So there has to be some reason when we give metformin. We can't just give metformin to all PCO women. Actually, we can and may, because PCO is very, very metabolic in
Yes.
nature.
Yeah.
So PCO, but the guideline says we should not. But honestly, I think metformin is a super drug. It is going to change the metabolism. It is going to create sensitivity to insulin. So we are not talking of ovulation or fertility here, but overall, the PCO woman is going to be, if untreated, pre-diabetic. It's a metabolic disorder. But obviously, we don't have any guideline which says that give metformin to all.
So I want to share one experience. I used to see a lot of young girls who have been treated with metformin in the adolescent age for the PCOS at the 18th year, 19 years, and they come to us for fertility. They have a previous history of treated with metformin. They fare very well for your ovulogens. That they have a very good response when you stimulate them with your clomiphene. So when they are pre-prepared with metformin before their marriage or before getting into the fertility, they have a very good response. So when you treat them in a younger age for a PCOS with metformin, they have a good result of the stimulation outcome, and they fare well to get a pregnancy faster.
I fully agree on the point.
Okay, ma'am.
If it was my sister, I would do this. I don't know if it is evidence-based or not, but it looks very logical.
Sure. Thank you very much for your points, ma'am. Can we usually have Dr. Pandian say a few words to us at the end of the. Professor Pandian, I request you to say a few words.
Thank you very much for the nice talk. Very informative. I've got a few points to ask you or agree with you or disagree with you. Do you do insulin levels for all your PCOS patients?
No. I think it's only for epidemiological. It's not
Okay.
clinical practice. Yeah.
Okay. Thanks for the good information that PCOS patients have a late menopause, their fertility is good. Is it observation or literature?
No, it is a study. I can share with you. I can
Okay,
share with
please.
you.
Great. Okay. I mean, I'm glad about this PFOD also. I think you should make the move. You should recommend that it should not be PCOD, it should be PFOD. Is it been in literature?
I think I'm going to do it. Yes.
Yes, please do it, because PGD changed name. PGD became
Many
PGT-A.
people tried. Many people much bigger than me tried and failed.
No. Somebody has to make a beginning. So I think you should do it. We'll support you.
Thank you.
Okay, and the testicular capsule is as thick as the ovarian capsule. They both have the same origin. So you're mentioning about the capsule for the ovary, they both have the same thickness, more or less. This is just an observation. And final thing, which is not going to be pleasant to hear, I do not know if there's any indication for recombinant FSH at all. Whatever purpose.
Absolutely agree with you.
I'm glad.
Because PCO was only taken the only indication where it's had a major role, but even that megaset trial has thrown it out of the window.
Yeah.
So I think the whole thing of recombinant, I'm not sure if it is it's just that maybe efficient. It's more efficient.
Not really.
That is not proven.
The only advantage claimed was about the purity of the product and the batch consistency. And you really don't require it. Recombinant FSH is not superior. In fact, Cochrane said long time back, no need for any more further trials at all because HMG is good enough. Only thing you need a HP, high purity HMG. Anyway,
I think till the year of 2010, all the conferences used to have these talks. Which drug, HP or urinary? No conference now has that talk. Because so that is a self-explanatory answer to your question, that since 2011 I have not seen this as the topic of the conferences talks, and before that this used to be the constant topic for all conferences.
Okay, one last question, do you still burn the ovaries?
No, not very often, but like I said, if I was working in a village in India where people are not going to come back to me, they're not going to do multiple rounds of IVF, and I clearly see there is hyperandrogenemia with stromal abundance in the ultrasound, then I will do it.
Okay. That again, we stopped long time back. 94 history, we had a paper saying that.
I don't think there's any place for stopping anything which is working for many people. It's only stopping because we have an alternative, very effective therapy, which is non-invasive, largely non-invasive, which we call IVF. But when not everyone still, I think 1.2 billion people in India, not everyone can do IVF, and that also multiple times. And drilling is a very cheap single attempt, and they might make the woman ovulatory when stromal abundance is there, when hyperandrogenemia is there, and they're not going to do IVF. I think that we could off our hands without drilling.
Yeah, we could go on forever because it's a big topic, but just one word, the same woman would benefit with weight loss rather than going through a drilling and losing her ovarian
reserve. That is not proven yet.
There is writing on the wall. Anyway, we know that weight gain is the main reason for PCOS itself.
But the combination will be very good. So that person loses weight, and if at all there is or no drilling, whatever. Obviously, not everything needs the data. So something which is logical, we should not wait for data. Obviously, I agree with you.
Thank you very much. It's been wonderful.
Thank you so much. That was very, very good to be with you all. I actually felt very loved today. So thank you.
Thanks a lot.
So from IFReF, I was really happy for the wonderful discussion that we had today. Looking for many more academic interchange like this. So my heartfelt thanks to Dr. Anu Chawla, first of all, for bringing in such a controversial topic which has so much of differences of opinion in it as a whole. PCOS is like an elephant, a blind person touching every part and then finding it different. So
Yeah.
thank you for coming and being with us and choosing such an interesting topic. And Dr. Ajanta, thank you for introducing Dr. Anu Chawla to us. And I would like to thank my chairpersons, Dr. Jairani Kamaraj, amidst a busy schedule and at an odd time in the night to spend so much of a time with us. Thank you, Doctor. And Dr. Pavitra for being a very, very interesting discussant. And thank you, Dr. Pandian, for ever being there to give us the academic support. And I want to thank Sustain Senora team for giving us the technical support. Very good night to all of you in India. Good evening to you. Bye. Till we meet next month. Thank you.
Thank you very much. Thank you very much to everyone. Dr. Pandian, Dr. Jairani, Dr. Pavitra, Dr. Kritika, and I didn't see Ajanta yet. So thank you very much, Ajanta. Hello.
Yeah.
Thank you very much.
Thank you.
Thank you.